Well, welcome everybody to today's Weber teleclass. My name is Martin Kiernan, and I'm an infection prevention specialist working in the UK. And I have the great pleasure to host a number of the teleclasses, but often no more pleasure than hosting one of today's speakers. Today's speaker is Professor Hugo Sachs. Now, Hugo worked for many years at Bern University Hospital and the University of Bern. He's retired from them now, but has not, well, his definition of retirement isn't many people's. So he's no longer actively working in the hospital, but he's working in the area of research, and he's working on many exciting projects, including looking at transmission of microorganisms through nanoparticles. He's interested in the use of computer visions, cognitive science, hospital architecture, design. He now has his own consultancy, which is SachsHealthDesign.com. He's also looking at a crystal ball initiative, trying to predict future trends in infection prevention and control as well, which you can find on the Sachs Health Design website. He's published many seminal papers, having first started publishing in 1999 with a paper looking at epidemiology of healthcare-associated infection outside of the United States. In 2007, he published his seminal paper on the 5 moments for hand hygiene, which is so familiar to us all over the world. And then he focused for many years on behavioral aspects and how to help people implement infection prevention measures before diving back into the world of epidemiology, writing some of the seminal papers on the Mycobacterium chimera outbreak that was associated with heater coolers. So today we're going to be going back to hand hygiene, and I'm very much looking forward to this. So welcome, Hugo, and please give us your session entitled Hand Hygiene Reloaded.
Thank you, Martin, for this really nice and warm introduction. And I would like to jump right into it and lead you to the slide number 2, which shows actually where I got the title from. It's the movie Matrix Reloaded that came out in 2003. And the main actor had a choice between a red pill and a blue pill. And the red pill stands for the willingness to learn a potentially unsettling or life-changing truth, or the blue pill remaining in a comforting ignorance. And so in that sense, I would like to take a closer and a very personal look into pathogen transmission and what that means for infectious risks in healthcare and for patients, and what it means for the prevention of these infections by hand hygiene. And I think what the unsettling truth is that we don't still not know everything about the transmission and the relationship to infection, which makes us nervous and uncomfortable. But it also gives us some drive to dig deeper and look at it more closely. So I will talk a bit, rewinding the time, look at the origin of the 5 moments of hand hygiene concept that got then promoted by WHO, and especially thanks to Didier Piquet, became a worldwide standard in healthcare infection prevention, and look at the effect of hand hygiene on infectious risks, and discuss some unconventional hand hygiene studies, and finishing off with looking a bit into the future. So in slide number 4, I would start with the making of the 5 moments, long before it became the WHO 5 moments. And actually, when you go to slide number 5, that is where it all started for me personally, with the preparation of the Swiss hand hygiene campaign, and that was roughly in the year 2004, so just 1 year after the Matrix movie came out. And preparing this hand hygiene campaign that I had the honor to lead in, and that was rolled out in 2005 and 2006, we wanted to measure hand hygiene and teach, train all the hospitals in Switzerland that were willing to participate in hand hygiene, and we wanted to measure the baseline before the campaign and then after the campaign in 2006. And so I took the occasion of a meeting of infection prevention practitioners, mainly nurses, that came to Geneva at the time from different hospitals around Geneva for an afternoon to do an experiment. And actually I showed them a video of 7 minutes of real care. It was showing a nurse and a doctor caring for a patient who came out of the catheter lab. And so they had to do some manipulations around this patient. And I invited all the infection prevention practitioners to fill out a form while they watched the movie to register all the hand hygiene opportunities. And you can see how many opportunities they saw on the left graph. Actually, you see on the x-axis the number of hand hygiene opportunities, and on the y-axis how many people voted for each of these number of opportunities. And the light gray columns represent the first screening of the movie, and the dark columns represent the second go they had at it with the second screening of the movie after we discussed hand hygiene indications. And at the time, there was a list of roughly 72 hand hygiene indications that were described in detail. On the right graph, you see what they judged the compliance or observance, as we called it, of hand hygiene in this movie, and you can see that this is almost a random distribution graph, how the different experts judged how good the doctor and the nurse cleaned their hands in this movie. So this brought me to the idea that it is not possible that experts have such a diverse view on what hand hygiene should be, because that would make the healthcare workers feeling that hand hygiene is a mystery and only the infection preventionist could judge what good hand hygiene is. So going to the next slide, number 6, we started a series of experiments in simulation settings, and sadly I cannot show you in this broadcasting now the videos, to see what would be a simple way to have a simple concept and human factors approach to when hand hygiene should happen, and create a kind of solid mental model that people could then apply to different healthcare settings. And you can see in this movie Pascal Erro, an infection prevention nurse in the team of Didier Pitte at the time, who was very helpful in all these simulations. Next slide, number 7. In the beginning, we imagined always 2 patients to depict the potential transmission from one patient to the other. And you can here see the concept of a representation of patients in their bubble with their flora that they brought into the hospital, and how hands travel from the patient A over the hand hygiene dispenser in blue in the middle, going to the patient on B on the left side in green, and there would be no transmission in the left picture. In the right scenario, you can see that this hand hygiene is mixed by the hand hygiene dispenser not used, and you can see that the patient B in the left bed gets red and becomes colonized potentially with the germs coming from patient A. So that was the first idea that we had to represent and look into hand hygiene or hand transmission. When you jump to the next slide, number 8, you can see that we also tried to figure out when exactly hands would have to be cleaned while touching, before touching the patient, touching a surface in like the bedside table, the surface in the immediate vicinity of the patient before touching the patient. And this is then linked to the question of the 5 moments, and I will come back to that later on. Now going to slide number 9, because at the time it was already clear what still is an issue, that observers have different views on how to register hand hygiene when looking at the activity around the patient. So I had the idea to create a tool, a digital tool actually, with a touch screen that depicts here on the left side a patient in the bed, and you have to bear with me or believe me that I wanted to show here a patient on that screen. You can see on the left the head and on the right the feet, and in brightly yellow you can see the bed. And around this bed and on the patient there were different buttons, touchscreen buttons, that you could click on that would represent just when hands of healthcare workers touch something. And the idea was to free the observer of knowing any rules and just observe their hands touch. And then this would, the computer program that I wrote would then know when hand hygiene would happen between 2 touches, going, for example, from the table on the left top to a dressing change on the patient. The problem was, at the time, there was actually no touch screen that existed in 2005, because the iPad, for example, the first iPad was introduced only in 2010, so people would have to run around with a laptop computer on and use a mouse or the trackpad to press these buttons to see what happened in the environment and get the hand hygiene observation done. In the next slide, so I tried another approach, and this is a semantic observation tool. You can create with these different words in a sequence that makes sense to make little sentences and to denote what was touched in what sequence, and then the program would figure out what the hand hygiene observance was. But this was not very practical, because sometimes things happened that were not possible to write down with this system. So going to the next slide, number 11. I don't know who is now in this broadcast remembers the Palm Pilot as one of the first handheld devices. There was by Apple a device that was called Newton that I also looked into and even owned at the time. And here you can see then the startup screen. We got a bit more modest on how to do observation. And all this work actually was linked to the idea of have patient zones, because these programs, when you touch 2 things in a row, would then create a hand hygiene opportunity and would evaluate if there is hand hygiene between touching, for example, a surface outside of the patient zone and then the patient's intact skin. So, thinking about all of this, I went into having a closer look at how pathogen transmission actually happens. And there we go to slide number 12. And here you can see two surfaces, surface number A and B, and they are colonized with a germ now that's called lowercase a with the red triangles and lowercase b on the surface B on the right side. And the transmission would then, in the scenario number 2, transmit the germ A to the lowercase, to the surface number B, and in the third state, we would have this colonization of the surface number B with some germs that come from the surface A. Now, since most of the bacteria that we know in healthcare that create healthcare-associated infections, they are not airborne, are not droplet transmitted, but are transmitted by contact. And so they need actually a surface that travels from the surface A to the surface B to do this transmission. So this whole transmission actually has two different components. It has the component of the contact where actually the transmission happens between the surface A and the hand, not the picture here, that would exchange the pathogens, and then the hand would travel through the geographical space to the surface number B, and there would again happen a transmission between the two surfaces. And so when we go to slide number 13, there I tried to dissect this transmission between the two surfaces that touch each other. There would be the surface that is in a bright rose in the middle, upper middle of the slide. And you can see the pathogens of round red representations, and the yellow surface would then be the other surface. And so when the two surfaces touch each other, there would be a transmission, an actual transmission of pathogens going from one surface to the other, for example, from a hand to a skin of a patient. And I thought about what are the elements that determine how many, when the two surfaces touch and then depart again from each other, what would determine that some of the pathogens being on the hand would end up sticking to the skin of the patient. And some of the factors are listed here, like the germ load on the hand, then the relative adhesion to hands and the patient's skin, the nature of the surface, humidity that we look in later on, temperature, obviously the load of germs that are on one of the two surfaces. And then actually when a surface, for example, is on the shoulder of the patient, it is a question how these pathogens then from the shoulder go to, for example, to the nose of the patient where they colonize like stuff, how they travel from these contact sites when, for example, you help the patient to move upwards in her bed, and you touch the patient on the upper arm, how would then the germs end up in the nose, for example, the MRSA that you had on your hands before. And obviously from there would be the whole question, if this colonization stays a colonization, how long it stays, and if this colonization then leads to invasion and overrides the immune system and it becomes an infection with the latency. So this was kind of a reflection at the time that's still in my mind nowadays, and it's still the kind of story that we have to look into when we think about hand transmission and infection. Now, in the design of the 5 moments of hand hygiene, as I said before, we first thought about representing this as 2 patients and how transmission happens between the 2 patients. And you know from the famous graph of the 5 moments of WHO that it was what ended up to be promoted. Jumping to the next slide, number 14, there you can see this great sticker that was developed in the UK hand hygiene campaign that inspired me greatly for the Swiss hand hygiene campaign. And it was Julie Storr and Gabriel Teague, a marketing professional, who came up with this great idea of the point of care. And I really adhered to the idea. So when you go to the next slide, number 15, it ended up being all around this one patient and the point of care where hand hygiene should happen. Now, here you see that there is this idea of bringing in the pathogens with the number 1 indication of hand hygiene into the patient zone, these 2 zones, healthcare zone, patient zone, and then even within this healthcare zone, the transmission of pathogens from somewhere, even within the healthcare, the patient zone, to an invasive body site, like the insertion site of a catheter or a mucous membrane, and similarly to get hands colonized with germs from sites where there are a lot of germs and transmitting within the patient zone and maybe infecting yourself, and then the number 4 leaving again the patient zone. And so there is a kind of 4 moments for hand hygiene, and at the time the experts that gathered at WHO didn't think there was enough evidence that by touching the close environment of the patient, there would be a transmission of pathogens going from, for example, the bedside table to the patient, which made then the great thing of 5 moments for hand hygiene, with the 5th moment touching only the environment of the patient. But it got the whole system the whole concept a bit more complicated. And so a number of countries use now a 4 system of hand hygiene that is simpler and more symmetrical, amongst others Canada and a few many hospitals in Switzerland as well. And so here we are in slide number 16, what came out of all this work that was continued with a lot of help also to WHO. You know, all the movies, Benedetta Allegranzi helped, and even figures also enacted in these movies to teach people the 5 moments of hand hygiene. Now going to the next slide, number 17, at the time I also made some back-of-the-envelope calculations that I think are still interesting to discuss regarding the risk density in hand hygiene. And I once calculated that each half year 1.3 million hand hygienes were missed in the hospital in Geneva in half a year, so roughly 3 million in a full year, or 7,500 every day. But I also calculated by numbers of transmission of MRSA that one healthcare worker would have to do correct hand hygiene before touching a patient for 1.5 years to avoid one transmission, which speaks to the low density of risk for each hand hygiene moment. But since you don't know when it comes up, you have to do hand hygiene all the time, otherwise you will miss this one opportunity where actually a transmission happens. And I will come back to this later on. Now the next slide, I would like to jump over and go to the next slide, monitoring hand hygiene. That's slide number 19. There, in the next slide, number 20, there is a great approach to monitor hand hygiene, because it would really be useful to learn more about hand hygiene. And the group around Dr. Philip Polgreen in Iowa experimented with computer vision, and they used the Microsoft Kinect camera with additional software that they developed. And this video camera has a depth sensor built in, and they, what you see on the picture on the right side, they marked a space around the patient bed to see if hands would penetrate into this space, into this cube, which would be closer to actually touching the patient than just someone walking into the room, like many systems. Automatic hand hygiene observation systems would just register someone walking close to the patient. This system actually looks at the hands if they go into close to the patient. The video actually only exists for milliseconds, and then the software just tells you if the hands were in the bed or not. And they also used this system to see if people would wear gowns, masks, gloves, and so forth, and tested it against human observations. And on the next slide, 21, you can see some of the results on this study, and you can see that sensitivity and specificity was very high against human observations. And in the right graph, you can see some of the hands that go into these spaces, and they are actually in there only seconds to touch the patient or his very close environment. So next slide, 22. Roughly in 2006, cameras, very small cameras, became available, and you can appreciate how bad they were by the flawed images, the blurred images. But maybe you can see that I put one of these cameras on my head, and on the right side then filmed my head touching stuff in my office at the time. And now when we jump to slide number 23, fast forward to 2016, so a long 10 years later, we finally managed with much better cameras, with GoPros on the head of nurses and doctors in the ICU, to film what their hands touched during real work. And they really forgot they had the cameras. Often they told us they only realized it when a colleague asked what strange things they were wearing on their head while they were working. And going to slide number 24, you see the results of these studies. So we filmed around 300 minutes in 10 videos, 8 with nurses, 2 with physicians. And overall, we then coded Manuela Cottoni, a master student, a medical master student, coded these videos and found 4,222 hand-to-surface exposures of the both hands. And so every 4.2 seconds, these people working in the ICU touched something, and they touched it for a duration of 7 seconds. In 21% of these touches, the hands were wearing gloves. Now, what is astonishing is when you look at the objects in the table below, that mobile objects outside the patient zone accounted for 61 of these hand-to-surface exposures, and inside the patient zone nearly 80%, overall 61%. So there was a large proportion of touching surfaces was touching mobile objects, where immobile objects were less touched. Something you wouldn't probably expect if you just imagine what we touched. The patient impact skin only inside the patient zone was only 10% of all touches, and overall of all the 4,000 touches, it was only 4%. Now, the patient critical site was within the patient zone, because it's ICU, 28%, and also astonishing, the healthcare worker's own body was touched in 10%. Jumping to slide number 25, looking at infectious risk moments, which are moments when there was a transmission or a transfer of hand touching something outside the patient zone and then inside the patient zone. Hand hygiene happened out of 508 times, only 17 times, so 3.3% of adherence to these to actual transmission potential from outside the patient zone into the patient zone, touching the patient with hands that had touched something outside the patient zone of 291, and only in 14 cases the hands were actually cleaned in between. And patient infection events touching something, a critical site on the patient's body, 217 with 3 hand hygiene cleaning, so 1.4%. This means that if you look very, very closely at these very frequent touches of surfaces, there is much more hand transmission possible than you would imagine, and that's usually observers capture when they look at care. So this is kind of a reality check. Now going to, this leads us to the next slide, 26, thinking about how many of these hand touches actually end up in an infection. And again here, a picture of the movie Matrix. So jumping to slide 27, there is this classical model what an infection is, a germ that jumps on us and infects us from outside, called exogenous infection. But there is the other possibility to get infected with endogenous germs, which germs coming from, or pathogens coming from our own body. And so there is a great study on this, on the next slide, 29, that looked into this transmission question. Is actually the healthcare-associated infection a transmissible disease? And some years back, I often said, actually, it is not. It is an infection that happens within the body of patients and is triggered by either the disease of the patient that they come in with to the hospital, or with invasive treatment that we at the hospital give the patient to treat the disease. So this study that was done in Berlin, and Hajo Grundmann did it in the group of Peter Gastmeier. They looked in 5 ICUs over 18 months and typed 10 typical healthcare-associated pathogens, typed them genetically, and did a daily chart review. And so these patients got screened almost daily for their pathogens, if they had an infection or a risk of infection or a suspicion of infection. They got their clinical samples, and they allowed for a 9-day time window of the definition when 2 patients had the same genetic profile of the same pathogen, to call it a transmission. They gathered 28,000 patient days, 278 infections, and with these 10 pathogens, and overall there were 431 infections, and actually only 41 corresponded to a germ that was transmitted from one patient to the other, which equals 14%. So the conclusion of that study was that only 14% of all the infections could have been related to transmission. And they didn't only look at multi-resistant pathogens, but all pathogens that they isolated from the patients. So look in slide number 30, looking at this from another side, to understand how many of the infections actually are created by a transmission and can be prevented by hand hygiene. When you look, for example, the 4 major infections of the healthcare-associated infections, when you look at the urinary tract infections, it is hard to imagine that the risk of bringing a pathogen to the urinary system against the risk of these pathogens coming from the patient's rectal flora is really low. And this is also in the other healthcare-associated infections. When you look at the pathophysiological pathway, that it's rather more likely that infections come from the flora microbiome of the patient, triggered by an invasiveness of the treatment. Next slide, 31. We looked in a systematic review and meta-analysis into how many transmission happens, and it is often that microorganisms get transmitted. When you look into these studies, the studies looked mainly at potential pathogens being transmitted from patients as a source to healthcare workers or the environment. And there were only 2 studies looking at the transfer to the patients, and actually it was within the patient's environment. And the meta-analysis where we could do it showed that most body sites, human body sites, were a risk factor for transmission, longer duration of care, and care for patients with invasive devices. So conclusion is that transmission is happening very often. And looking at the next study, where we used nanoparticles, silicon nanoparticles with encapsulated DNA, and actually this encapsulated DNA was only there because we knew then their sequence and could identify the nanoparticles by destroying these silica encapsulation and the capsulation by armor of glass, and then use the cyclers to understand what DNA code were in these nanoparticles. And in a scenario that we played and put these nanoparticles in 3 different batches of different sites during this scenario, and they had different DNA, so we could distinguish where they ended up. And the next slide, number 33, shows the result in the graphs on the graph on the left side of these 3 batches brought out of different stages of the scenario. The scenario was replayed 3 times. And it was interesting to see when you look closer at the 3rd blue graph that when nanoparticles were brought out on the left forearm of the patient, and actually the healthcare worker who played the scenario then tested the pulse of the patient and got the 4 fingers contaminated, that afterwards manipulations like infusion valve regulation got also contaminated by carrying over these nanoparticles, very specifically when the 4 fingers touched again the object, speaking to the specificity of different fingers or different parts of the hand being colonized. On the right side, we tried to see how the nanoparticles got diluted by propagating them from touching one surface of the other in parallel E. coli to the nanoparticles, and you can see that both the nanoparticles quite nicely imitate the dilution that you get by the transmission over different surfaces by the hands through bacteria. And this brings me with the next slide, Kovadi, to looking at what hand hygiene could be in the future, or the research. And there is a nice overview paper by Nazim in the group of Didier Bitte, who looked at hand hygiene promotion over the last 20 years. And she put a long list of research opportunities in hand hygiene in this paper, and I picked out 5 of them. And when you look identifying the best methods to recover microbiological pathogens close to the clinical context, also number 5 being similar, identifying these germs. And then what I also think is very important is identifying the contribution of the 5 moments to specific infectious outcomes, and simplification of the 5 moments, or looking at alternative hand hygiene concepts, specifically because, as I said, you have to do a lot of hand hygiene to avoid one actual transmission. So being able to better know when this transmission happens, and this is really a bit futuristic, we could reduce the need for hand hygiene, which would increase the compliance, as we know. And with this, I'm coming with the next slide to a conclusion. And one of the conclusions is the idea behind the 5 moments was to create a simple and robust mental model, but we are aware that it clearly needs system design around it, and maybe simplification for a successful implementation. And this is specifically true for certain environments that are very busy, like in anesthesia. The exact contribution and pathway of hand hygiene transmission to infection equally needs more investigation, and some of the computer vision capabilities and also better tracers could help us to understand this pathway better and then cut hand hygiene or other measures more closely to that risk. Further, a detailed account of hand-to-surface exposure, as I said, could help in better understand this transmission. And as a really utopic idea would be a precision infection prevention in analogy to precision medicine that would tell us healthcare providers when a transmission is very likely going to happen, which would decrease the need for general hand hygiene and increase adherence. And with this, I come to slide number 37, and would like to, like in the movie Matrix, give credit to some great people that helped me to understand better what happens and promote the results over a larger field of research and a larger community. And with that, next slide 38, with a picture of my passion of flying and looking at the world sometimes upside down, I would like to give back to you the microphone, Martin.
Thank you so much, Hugo. Yes, that's a fantastic last picture. Not many people finish with a picture like that. But you're right, the world is upside down all the time. Just to reassure you, I am one of the audience who does remember the Palm Pilot, but then again, I also remember papyrus and parchment as well, so the Palm Pilot was actually something new to me. And I really quite like your early slides showing the red pill and the blue pill. And I think many of us get that choice every day working in infection prevention, whether to actually think, do we know enough now? I'm just going to take the blue pill and not try and learn any more. But for others, it's continually taking the red pill every day because we want to almost remain uncomfortable in the fact that we know we don't know enough. You know, many people would think, oh, we must know as much as we need to know about hand hygiene, but as slide 36 shows, and slide 35 shows, there are so many more opportunities to do further research. It's almost unbelievable. And I say to many people, the longer I work in this field, the less I seem to know about it. And I'm in quite a lot of danger of finishing my career knowing that I know less about my subject than I thought I did when I started it. Can I make a couple of points? I mean, you made a great point about halfway through talking about surface touching outside of the patient zone and mobile objects, when I suspect people are maybe more likely to do hand hygiene when they're around the patient area and therefore much less likely around these mobile objects. But often the mobile object can be actually the source of an organism that can be transferred to something, the ultimate destination is inside the patient zone. And do you think we've done enough talking to people about hand hygiene outside of a patient zone? Or do you think really if we can implement the 5 moments extremely well, then that almost becomes immaterial? But then I'm wondering, do you create these reservoirs that patients who are actually quite mobile might pick up organisms from these objects outside of the patient zone?
Yeah, I think that's really so. Behind everything is this low level of risk for each single event, So, but it is true that when you bring something inside the patient zone, a surface, then the surface is actually, if you want to see it that way, still out. If it's not cleaned while it goes, like the hands would be, like when it goes into the patient zone, it's actually bringing the healthcare zone close to the patient, and it becomes like an indent in this bubble around the patient. And so when you forget that and assimilate it to being part of the patient zone, then you don't do hand hygiene. And if you touch this a lot, then there is obviously the risk that you bring pathogens, bring these germs that are on this object to the patient. So I looked a bit into the situation of anesthesia induction, and there is a discussion about, for example, tapes that are used to fix all kinds of swords on all kinds of things on the patient, and these tape rolls then are put on the side, and they are certainly not thrown away between each patient. So they are actually the healthcare zone that is brought close to the patient. Now the question is how big is this risk, and we don't know. It can be if it's a bad situation, then this role can become contaminated with something that you really don't want to have on every patient, and it could end up on every patient.
Yeah, I mean, because the patients really don't always stay inside the patient zones. They are frequently going to touch these objects outside of the patient zone, be that items at the nurse base or the staff base, or other common items around the organisation. I mean, I was quite reviewing Hugo's paper from 2005, and they found relatively limited transmission, but with the typing of the day. Do you think that would change now with the genomics, the whole genome sequencing we have now, because they only looked at 10 of the common pathogens? Do you think that might be different now?
Yeah, I don't know. I think there is, since years, I think there is room for a really well-designed study to look again into this. And there are studies looking into the microbiome of the hospital and the patient. The challenge is obviously to find all the germs that are hanging around the patient and on the patient, to be sure to detect a new colonization. And in my thinking, we often are alerted by a few patients in the same space and in the same time period having the same multi-resistant pathogen showing up. But we never think about all the potential outbreaks that go below the radar because they are not multi-resistant, and we don't realize that the sensitive E. coli could actually be transmitted from one patient to another and contribute to the risk of infection by being more virulent, or the patient less used to this type of E. coli.
Yeah, I agree. I mean, in those days we weren't really looking for the plasmid-mediated outbreaks either, that we now know can be quite significant and quite difficult to detect if you've got an Enterobacter and then an E. coli and another gram-negative pop up, and it's the same plasmid getting around, but it's quite difficult to detect those outbreaks transmissions. I agree with you about the well-designed studies. I mean, to what extent also can we factor in the actual transmission risk from the patient themselves, depending on where they're colonized? Somebody who's just throat colonized with MRSA is presumably a less transmission risk than somebody who maybe has an exuding wound. I mean, how can we factor that sort of thing in, do you think? And the activity of the patient themselves, somebody who's bedbound is fairly contained, but somebody who's all over the ward is much contained.
Yeah. Well, there are many then almost epidemiological factors that we have been discussing in the last 2 years because of the COVID pandemic. Very often, what all these factors come in and where you can break the chain. And you mentioned plasmid. Obviously, this is also something that, like not having a different phenotype or a phenotype that sticks out, like in multi-resistance, is an additional factor that might make us miss transmission.
I mean, it's interesting to hear you talk about you might be able to reduce hand hygiene. If you could identify an infection-related event or an infection risk event. And I actually remember a paper from Clive Beggs years ago when he was modelling hand hygiene and what was the, where you got the optimal. And I seem to recall it was if you genuinely did stick hand hygiene about 60% of the opportunities, you probably would not get a lot more benefit than by doing it a lot more often. Do you subscribe to that view that you will, if you can get it going often enough, you will actually reduce transmission? Or that doesn't really look at infection risk events, though, does it? Which is what worries me, because some procedures are much more risky than others, obviously.
Yeah, this looks more into the relationship between how often you do hand hygiene and in the mean. And as we know, for example, from now the reflection on how much immunity has to be in a population to get rid of an outbreak, there isn't an even distribution that just with every percent more people vaccinated, the number of new cases goes down in parallel. There are these threshold effects that all of a sudden a few percentage more immune people can make the epidemic end. And we know it's very high, and so this uneven relationship between hand hygiene adherence and transmission is probably also happening. And I think if we could map better these every hand traveling to the hospital or at least in a patient room or a ward, then we would be able to do some simulations like they do for SARS-CoV-2 now.
Yeah. And lastly, can I put you on the spot and ask you what you think is the, I'm not going to say best, but a functional and usable way of actually monitoring hand hygiene at a hospital level to actually give something meaningful to be able to feed back to people, because direct observation has its issues. Electronic monitoring doesn't pick up on the 5 moments. What would be your preferred method if you were running a hospital now to monitor hand hygiene compliance? And I'm not a fan of the word compliance, by the way.
I think from a scientific standpoint, and that is not your question, it would be the development of a multi-sensor system that would really track the touching, each touch of a surface.
Yeah.
It's unlikely that such a system becomes usable throughout the hospital.
Yeah.
But for research, that would be my answer. For a hospital, I would look at the combination between use of hand drop by wards or so. Then you have the 24-hour and related to patient days or even patient care activity if you have this data. And in some instances, punctual where you needed do some observation with which is a combination, on-site observation, which is actually a combination of an intervention and measuring hand hygiene. That would be my answer for the everyday in the hospital.
Okay. Thank you very much. It's very kind of you. Well, we've come to the end of our hour. I've thoroughly again enjoyed our session, and it remains for me to thank Hugo for another tremendous session. I look forward to the one he's already committed to for next year, because Paul has already buttonholed him for next year. And to everybody else, I'd like to just point out on slide 39 the tremendous sessions coming up over the next few weeks. So we've got Discovering and Transforming the Inner ICP Educator. We've got the Sanitation Economy and Public Health. Andreas Voss is going to be talking to us about emerging fungal infections and infection prevention and control. And perhaps the most worrying one is on December the 16th, which is Professor Stephen Morse talking to us about COVID-19 as a dress rehearsal, the rise of disease X. So that's a cheerful way to head up to Christmas. Moving on to slide 40, can I thank all the patron sponsors who make teleclass education possible? It's Diversity, Virox Technologies, Gamma Healthcare, Purell, and the World Health Organization, without whose support it would be difficult to run these teleclass series. And again, thank you to Paul for facilitating. But just to close, thank you so much again, Hugo. Always a pleasure to speak and listen to you, and I will look forward to the next one. Goodbye, everybody, and enjoy the rest of your day.
Thank you very much, Martin and Paul, and goodbye to everyone.